Welcome to second day Health Impact audience. We've got a jam-packed first session for you guys talking about a really, really important topic, and that is chronic care management. There's a lot of discussion about technology in chronic care, but there aren't a lot of people pulling this off in safety net environments and doing it in a way that our friends at Welldoc have been doing with evidence and proof, with tools and technologies that have FDA approval. So there are a lot of tools and technologies that are out there that have not gone through the clearance process. But I know that Keith and the team, especially at Welldoc, have thought that that was very, very important, and that is getting evidence from the community and from actual users before taking it out into the world. This is going to be a really informal fireside chat with Karyn and Keith. Karyn comes from the New York City health and hospital system, and as many of you know, big city, but you may not be aware that an enormous amount of the safety net goes for Health New York City, Safety Net Health goes through that system. So with that, I just love Karyn, introduce yourself. We'll do the same thing with Keith, and then I'll pop in some questions. Go for it, Karyn.
Great. Good afternoon, everybody. I'm really thrilled to be here today to share our experiences at health and hospitals with the Welldoc app, Blue Star. My name is Karyn Singer. I'm an internist by training and preventive medicine trained, and I have been at health and hospitals after residency training. I went back and I've been back for about 6 years, and currently almost a year in my role, which is the AVP of Chronic Disease and Prevention, which helps to oversee chronic disease and prevention initiatives. And we run the data for the system specifically around diabetes, hypertension, obesity, smoking cessation, and we're now expanding into several new arms as well.
Yeah, that's great, and welcome, Karyn. I think that from the audience's perspective, as you listen to what Karyn is talking about, these aren't blue sky ideas. This is stuff that they're doing today, and so hopefully these kind of will create some questions in your mind, or you want to get some follow up. She'll be open to do that as well. Keith, tell us a little bit about yourself.
Great. Good afternoon, Shahid, and good afternoon, everyone. Thank you for being here. Karyn, thank you for presenting along with us and having this fireside chat. I certainly appreciate it. My name is Keith Reynolds, and I'm the Chief Operating Officer here at Welldoc. I've been here a little over a year, but I've spent over 26 years in the healthcare industry.
Perfect. So let's start off a little bit. Karyn, tell us about the NYCHH. We'll just call it HH here going forward. What is the diabetes program? Why did you guys entertain even looking at something like Blue Star?
Sure. So I'm going to take a step back, if that's okay first, just to tell you a little bit about our system, because you're absolutely right. We're a huge city. We are the largest municipal safety net system in the country. We serve over 1 million unique patients every year in our system across the 5 boroughs. We have 11 hospitals and 70 community clinics and larger diagnostic and treatment centers. And our patients are really very diverse from all parts of the world, all walks of life. And it's really a pleasure working at health and hospitals. In terms of diabetes, for the patients who are engaged in primary care, we currently have about 66,000 patients in our registry, which is across that system, 66,000 patients with diagnosed diabetes who are 18 to 75 years old. So it's quite a large number. And of that number, I can tell you that 65% are in control, meaning an A1C less than 8%. That's our cutoff. Of the remainder who are not in control, a little bit more than half have an A1C greater than 9. The remainder either have an A1C between 8 and 9 or haven't had a measurement on record in the past year, which through COVID was a much larger number. And then we were able to really get people in and bring it down as people felt more comfortable riding public transportation and coming into their hospital and clinic to get their blood work done. So why do we want to do a diabetes program? Because we have, of 66,000, if you take a third, we've got a little over 20,000 patients who are uncontrolled, and about half of those have an A1C greater than 9. So we've got a good amount of patients, 10 to 11,000, who really we want to focus on in terms of outreaching and really help them to get their diabetes under control. And there's a number of ways to do that, but we've had experience in the past with a text-based messaging initiative. Actually, it's been going on for 9 years at health and hospitals, and it's been incredibly successful. It's specifically for insulin titration, so it's much more focused. but 88% of our patients reach their goal, which is their optimal insulin dose. And patients feel, we've had over the years, many patients give feedback, and we've done studies on it. They feel much more connected to the healthcare system and to their clinical teams. And that engagement really helps them reach that goal. So we were really looking for other digital interventions that could help folks get to their goal when they're not within the four walls of the clinic, which is 20 minutes every 3 months or so. So that was a long answer, but I don't know if that answered it in a big picture.
Oh, no, that was perfect. So tell us a little bit about what is special about the SafetyNet part of your health and hospitals that might be different than other groups might be doing in other areas. So what is unique or specific to your challenges?
Sure. So I think there are some things that are similar to all SafetyNet hospitals, right? We have about 25 to 30% of our patients don't have insurance. And at our most recent check, about 44% have Medicaid. And then the remainder have Medicare or are dual eligible. So a large percent of our patients are uninsured or publicly insured. There's a whole slew of things. So again, there's a very big range within our population of resources. So socioeconomic status, insurance status, as I just mentioned, health literacy. Some of our patients have very high health literacy. Some may have come from another country and were doctors or nurses there themselves, and some or other healthcare professionals. And some have very low health literacy. Some of our patients aren't literate, not just health literate, but literate. So we have a wide variety. The other thing I can say is, as we span the 5 boroughs, we have multiple languages as a first language. So I can tell you, I literally just put in an order 3 days ago for a very large order for brochures and handouts for our patients for 14 different languages. Far and away, English and Spanish are the top 2, like on an order of 10-fold, but we definitely have, 13 other languages that are regularly spoken at our different facilities. And it depends on the different specific pocket. But I think that those are some of the things. And along with that, in terms of technology, some of our patients have smartphones and have regularly utilized apps, and some of our patients don't. Some of our patients may have plans that last all month, and some may not. Some may have a smartphone, but have a difficult time, utilizing the apps that are on it. I think that that's true of large portions of the population, but that's definitely the case for our population. So you kind of have to suss out who may be able to engage in this, but in my experience, it's growing more and more every day.
No, I love the fact that you didn't have all the answers, but you're saying this is worth doing anyway, right? And so You got to get it started. You have to know, in order to get things started, you're going to learn things throughout the process. And that's why, having a great partner like Welldoc allows you to adapt as you need to. But tell us a little bit about, Karyn, did you start this as a experiment and weren't sure where you wanted to go? Or did you have some objectives or outcomes or specific things that you wanted to accomplish? Where did you fit in that spectrum?
Sure. So we definitely had some specific metrics, some specific things that we wanted to hit. I mean, number one was to help our patients, lower their A1C. But I mean, you can just say that, but what does that mean? So help people know what are their sugars so that they're tracking them in a way that they can look in a systematic way. Oh, every morning my sugars look like this, but if I check it after dinner or after lunch, can I look at it in a way that makes sense, where I'm not just writing it in a straight line on a piece of paper? Can I get feedback pretty immediately? When you write your glucose number on a piece of paper, you're not getting any kind of immediate feedback, but Welldoc does that. And medication adherence. So if you choose as a patient to put your medications into the app can remind you when to take your medications, which is also huge. Those are some of the things. I think there are other tips, like if your sugar is high, the app may say, that's a little high, maybe you should go for a walk around the block. Or if it's low. So you get that kind of immediate feedback of, oh, I thought this was a good number. Maybe I was wrong. So I should lower it more. And we've actually gotten that direct feedback from patients.
That sounds great. And, one of the things that a lot of diabetics, especially the ones that are recently became diabetic, they went from pre to post-diabetic, they often ask, why is my number the way that it is? How are you able to work with Welldoc and your patients to try to help them understand that it is either their time of day or the activity or lack of activity or food? How do you get the whys answered for the patients?
Yeah, I mean, I think that's a really interesting question because we have these two measurements. There's one it's not static, but it's an average. And then there's one that goes up and down every day. And even just figuring out, what does this mean? What do these two numbers mean together, like the A1C and the glucose, can be a little confusing. And it's just not straightforward at first. So the app, what it helps to do is as you put in your finger stick, it will give you direct feedback and will tell you, okay, I can see that it's high after I've eaten something. So even though it's completely normal, I tell my doctor every day, I check it in the morning and it's perfectly fine. It's 100, it's 100 when I wake up, or maybe it's 160 and you thought that was fine, but this will tell you it's not. So there's various ways that it can be fine in the morning. If you're checking postprandial finger sticks, it will give you immediate feedback about that. Or there's lots of scenarios in which you can find your pattern about when your glucose goes high, and it will help you to understand that pattern and then hopefully bring that down by changing your diet or taking your medication or speaking with your doctor about it or doing exercise, which is a big one. That's super critical that our patients with diabetes are doing exercise when they can. So all of those things, the app encourages patients to do.
No, I love it. And in fact, right before I bring in Keith, can you comment a little bit about whether any of the patients that you're working with are on a continuous glucose monitor, CGM, and what does the future of that tech look like from your perspective as a practitioner?
So some of our patients are on CGM. Most of them are not on CGM because right now there's kind of stricter coverage questions or parameters around CGM, but definitely every day, more and more of our patients, my patient just got a Dexcom the other day. And I think, and Libre, I mean, those are the two that of course that we're seeing, but I think that they're helping to supplement patients who are using the app for more than the glucose. Because again, what the app does is it will give direct feedback and will help you with medications and understanding, like it can integrate the glucose readings with feedback. But what does that look like? I mean, there's more and more evidence coming out every day that CGMs are useful in broader and broader scenarios. So I have a feeling that we'll continue to see more CGMs, I hope.
Yeah, no, and that's great. The reason why I asked that is that there are some digital health programs that say, well, this is not worth doing until you get a CGM. I mean, you're clearly saying, don't wait for the CGM, start now, get it going, and it's going to be helpful immediately.
No. The minority of our patients, the minority of our patients overall who have diabetes are on CGMs, and it can supplement with Blue Star, but no, the majority of our patients who are on Blue Star do not have CGMs, and it's useful, very useful for them. So no, it's not a prerequisite. And in fact, the CGM, if it's tracking the glucose, people may not realize the value add of the app, but there is value add of the app and the feedback and the other components. So it's putting those together. So I think either way they can synergize, but without CGM, that's what it was built. It was built for patients without CGM as well. So it's definitely helpful.
Excellent. So Keith, tell us now, so you guys have been doing this for a long time, and I've been an admirer from far. I know you guys for a number of years, because you're driven by evidence and you're driven by, to pardon the expression, shit that works, right? I mean, it's not just stuff that's out there. Let's give this a try and see what happens. No, you had to go through things that work. So when Karyn and the team came to you from Health and Hospitals with their outcome requirements, with their needs, was that par for the course for you guys? Was there anything special about those outcomes? How would you treat that request from Karyn and team?
Yeah, I think generally we were really excited about the opportunity here. If you think about everything that Dr. Singer just said, the complexity of their population, the diverse needs that they have, some of the challenges that are posed to that community, we thought it was a terrific opportunity to really test out our technology in the most difficult population to reach and see what type of results that we could generate. And it's been really exciting to see that and the impact that we've been able to have on individuals. A couple things that Dr. Singer said that kind of jumped out at me. She said in the beginning, individuals spend about 20 minutes with their physician on about a quarterly basis. It's roughly about an hour a year that they spend with their doctor. Think about how long people are on their smartphone. In general, it's about 80,000 minutes a year, which equates to about 4 hours a day. If we can carve out a little bit of time to help an individual manage their healthcare and lower their A1C, that's a huge success. And that's kind of how we look at that. How do we fit into the life flow, if you will, of the individuals using our solution? So if they're in checking their bank account or they're using it for navigation, they are going to be in that on that phone using it for their healthcare as well. We're starting to see really healthcare and the smartphone merge together in a really elegant fashion.
Yeah, and so what I love about Blue Star, and one of the reasons you guys obviously gave that name, is sort of like a GPS is sort of when if you need help, you can press the OnStar button and get your help. So what's interesting about your solution is that it does similar to GPS in the sense that it calls you when necessary, rather than you having to just watch every turn, direction, et cetera, et cetera. And I think that's what you mean, is that they're already on their phone, they're already doing these things. If you can get them to be intervention. They don't have to think about the intervention, but the intervention or the nudging is happening in some routine way. That is actually ideal. So when you heard the requirement from health and hospitals, the way that it was, what was it that you liked about the way that they wanted to implement this? Was it more or less difficult for you guys to get started now that you've been doing this for a while? What does that deployment process look like?
Well, to answer your question about, again, what got us excited about it, one, the population that we were seeking out to serve, but then the integration with the delivery system was really exciting. If you think about it, we don't want digital health to live in isolation. We want to be able to support that patient when they're not in the office. We want to be able to help them understand the complexity of their condition and how to manage that and live a healthier life. And that's all the things that Dr. Singer mentioned. But the real opportunity here then is taking all that rich data that we have out of our application and integrating it back into the delivery system so that the care team or the healthcare provider has actionable insights. They can actually see what is going on with that patient. How are they doing with their diet, their exercise? How are they doing with their medication adherence? All the things that go into managing one's care now are exposed to the healthcare provider, where maybe before the patient would come in, they would answer a couple questions, tell the provider, yeah, I'm doing great. But when they go to get their A1C results, it's showing less than that. So really arming the providers with that actionable information, that was really an interesting part of this overall project and being integrated into the healthcare ecosystem.
No, that's great. And when you think about the SafetyNet side, I mean, obviously when we think of digital health, we always think of phones, and we always think of the fact that obviously if you have a phone, you have a data plan, et cetera. So talk a little bit about what happens if you don't have a data plan, if you don't have all of the heavy phone requirements. Is Welldoc useless, or is it still useful even without all of that?
Yeah, I would say it is not useless. One, our application works both online and offline. So if somebody doesn't have a data plan or they ran out of data and they connect to Wi-Fi, the application still provides that real-time coaching and feedback, and then it syncs up when that individual is within Wi-Fi range. In addition, if somebody doesn't have a smartphone, but they do have access to a computer, we have a web-based portal that individuals can utilize. And it is the same experience that one would get within our mobile application. So we are trying to make sure we meet that member where they are, that patient where they are, and provide them with accessibility via a web portal or in that mobile application to be used on or offline.
Perfect. And so, Karyn, if we talk brass tacks here, what we're saying is, in the last, if you think about this 10 or 15 years ago, there were these questions about, should we do digital health, and is any of this going to be, that's all gone, right? We know that this stuff is all useful. So the brass tacks come really in terms of integration, implementation, deployment. What did that look like for you guys? Talk to us about timing. Talk to us about, was it easy to start with the deployment process? What was the integration that you had to work on? Talk about the hard stuff because it can't be all that easy.
Right. So we actually did a pilot study first at 2 of our sites with about 300 patients. And this was pre-COVID. So this was 2018 or so. And basically what we did then was we set up champions at each of the sites, and we had regular calls. I mean, first initially starting, we're following the same model for phase 2, by the way, because it worked so well in phase 1. So we we spoke to the leadership at each of those hospitals, and they chose champions who would be real advocates for patients who know, who can pick out the types of patients who may benefit from this, both based on their A1C, but also based on their technology savvy or their owning of a smartphone and being able to have an app.
Just could you add on the personality profile? Who is this champion? Is it a nurse? Is it some administrator? Who are these champions?
So we leave that to the facilities because each facility has very different resource breakdowns, but it can look very different at each facility. So currently, we now have clinical pharmacists at each of our 11 acute hospital sites. In 2018, we didn't have them fully across the board. So right now, clinical pharmacists are some of those champions, nurses for sure. We have population health teams at some of our sites. And it could be a provider who's also helping to lead the charge, but it's not usually a provider who's getting folks to sign up for the app. Although I've signed patients of mine up for the app and it takes 2 seconds. Mm-hmm. If you have a patient who's technologically savvy, you just give them the QR code. Well, I can get into that in a minute because actually it's quite easy to sign somebody up for the app if they're familiar with technology. But initially when we did the pilot, we really worked with the sites to help them develop their processes and workflows. And although we had overall kind of standard suggestions, and I'd say it was really Blue Star based on their experience with other sites. We also have to mold that to each site because their resources may be different. One of the things that we're finding, and so in the pilot, we had 300 patients enrolled, and we saw an average A1C reduction of over 1%, which is great because that's clinically relevant. Now we're have expanded to actually 7 sites. So 5 hospitals and then 7 diagnostic and treatment centers, clinics. And what we're finding is each of the teams looks so different at each site. I mean, there's one location where 10 people show up to every meeting. They're really owning this. They're really excited about it. But the resources are different across the system and time allocation can't always be that. That site actually is interesting because their internet connection sometimes is difficult. So to actually get the patient to download the app while they're on site has been a little bit of a challenge that we found. But in terms of building that, that hasn't really honestly changed from past other than the webinars rather than in-person meetings. Mm-hmm. We've got weekly meetings. We meet with the champions. We hear what's going on at their sites. We hear barriers. We try to, stamp out the barriers. We get them whatever materials they need. And again, when I say we, it's our team, but also Blue Star. Blue Star has been an amazing partner in this. They've turned things around very quickly. And so we've really been able to troubleshoot a lot of those issues, things that didn't come up necessarily in the pilot because new things come up. The other thing that I'll say is the other thing that's new since the pilot is MyChart. So in 2018, we were starting the roll to Epic across our system. And in December 2019, we completed the roll, meaning all facilities and all 70 clinics are now on Epic. And so we have a patient portal, MyChart, which I'm sure you're familiar with. There's a secondary, not secondary, but a different initiative to try to get more and more folks signed up to MyChart. And as we've been able to do that, we actually realized that even via telehealth, we can send patients a link through the portal. If I discuss with my patient, look, this is an app that I think would be really helpful for you. Are you interested? Can I send you the link? They said, yeah. And I've done that and I've enrolled patients and they downloaded the app. I can see on the portal, they downloaded the app and they're using it. So that's a brand new methodology for enrolling patients, which has been quite helpful.
Yeah, I
don't know if that answered your question.
It did. No, that was perfect. I think really the difficult part is, and Keith, you know this from the software side, is we want to stamp out variation. Karyn kept saying each site is different. There's unique people, people are in healthcare. That's what makes healthcare so unique is it is the people at each site. What about that variability troubled you, if at all, or were you guys able to handle that level of difference between sites and other places?
Yeah, I think one, we have a standardized solution that everybody's using, and that has gone through FDA clearance. So we didn't have to necessarily change the solution to meet individual needs because the solution is very flexible in itself, and it's also available in Spanish, which was really important for this population. But what I would say is, as far as the implementation and looking to gain awareness and activation within the platform, is you have to approach this as a true partnership and understand that the assets that you have available. and how best to utilize those assets in order to drive activation and engagement in the platform. So in health and hospitals situation, they have physical assets, they have great care teams, healthcare professionals that could actually educate the patient on the use of the application. So identifying champions was a huge win. They're trusted advisors of the patient. And then how do you look at utilizing other modes of communication as well to be able to meet the patient where they are? My chart and sending links, that's a great example. Using text messages, think about emails, even direct mail and outbound phone calls. You have to really be able to use multiple modes of communication to be able to be successful in driving that activation. I like to say there's no real silver bullet in order to drive that experience. You have to utilize and run really essentially a campaign against it over time to maximize your results.
Yeah, what I was thrilled to hear, Keith, is that that Karyn and team are mentioning they have about 50% user engagement. That's a much higher number than is usual. She's already seen some early success signals come from this. So Karyn, you can talk a little bit about the early success signals, but maybe what I want to do in the last few minutes that we have is talk to the audience about what you learned through this process, about what worked really well on your way in, what you thought worked about as well as you wanted to, what you thought did not work at all, like you had to adjust quite a bit, and maybe some lessons that you could share with the audience about what they shouldn't do to maybe repeat some of the, and calling it failures is bad, but we all make mistakes, or some things you didn't think would happened during the thing. So talk about what are the success signals you saw, and then how would you do things differently, if at all, in the future, if you're going to run to your other sites?
Sure. So I think the biggest takeaway is that digital technology works for our population, and that's huge. I mean, patients really, for the patients who love it, they really love it, and it's really working. But I think that's the next kind of step, which is you have to do the right patient selection. So what we found was that of the 50% of patients who weren't very engaged in the pilot, they weren't really the folks who were actively using other apps prior to enrollment. And they weren't, for whatever reason. I mean, I could postulate as to why, but they weren't active app users. A lot of them, their first language wasn't necessarily English or Spanish, which again is fine, but some of them were actually not proficient enough potentially in English, because we asked them afterwards and they said I couldn't understand necessarily in the app. So I think picking the right patients is really key here, because they'll just take it and fly with it. I mean, I had the QR code on my desk and I said, in fact, I'm seeing her this Saturday. Her A1C was 9.6. I said, here's an app. She just put it on her phone right then and there. And I can tell you her A1C because I took a sneak peek and it's definitely below 8 now. So whether it was the app, we're going to talk about it Saturday. But the point is the right patient selection is really key to really utilizing this resource well. And as I said, I think that's growing more and more and more. But if someone has a good amount of hesitation, or you have to download the app for them, it might not be somebody who is going to use it actively, or they might be somebody who really wants to, but needs extra training on site with the champion or with somebody on site who can show them the ins and outs. Because some of the other feedback that we got was, I just didn't know quite what the next step was once I opened the app. Even though it's very easy to use, but it just takes a little bit of training for somebody who may not be used to utilizing apps. So I think that's the big takeaway. And yeah, again, it's just patient selection. Our patients are really thriving who are using it. We had over 1% A1C reduction in our 300 patients in the pilot phase. It's too early in this phase to say what the results are, but we're really excited about continuing to work with Blue Star and seeing how it goes.
Yeah, that's great. And in the last minute, Karyn, just maybe you want to add, and Keith, if there's anything you want to add with this statement, that you're never going to get 100% of all patients to do anything. Doesn't matter what it is, but a 50% engagement rate, 40% engagement, 60 is perfectly reasonable. So don't try to create a program which is looking for 100% success, because that doesn't exist. So in the last minute, just give a little bit of commentary around that idea. Start. And it's okay to not hit 100%. Is that all right?
I mean,
Yeah. Oh, go ahead, Dr. Singer.
I would say, sure, it's okay. Like you're never going to hit 100%. I agree with you, but we could do better than 50 if we choose the right patients. We have over 10,000 patients in our system who have A1C greater than 9 and another 10,000 greater than 8. So I think we could do better than 50% in the next iteration. But yeah, somewhere in the middle.
I love it. Keith, last word.
Yeah, I would say you want to set your expectations high and always shoot for that 100%. However, if you can impact a small portion of a diabetic population, there is a significant ROI that is achieved by managing your condition appropriately. So I agree with you. You can't not do something because it doesn't hit 100% of the population because of the benefits that it has for everybody using the solution. But you always want to shoot as high as you can. And Dr. Singer, I agree with you. I think we can go above 50%.
All right, fantastic. Well, this was a great case study. Thank you both for joining us here. And I'm sure our audience will have plenty of questions for you guys afterwards. So please reach out to the audience members and connect with either Karyn or Keith about what they talked to you about here. And thanks signing off for Health Impact on our side, and we'll see you at the next session.
Thank you very much.
Thank you.